Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and we are pleased to bring you VITALS in collaboration with University Hospitals of Cleveland. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service.
Thank you, Dr. Langell. I'm very excited to be here and participate in the innovative NEOMED VITALS seminar series. I'm going to go ahead and pull up my presentation. Today, I'm going to be speaking about a topic which I'm deeply passionate about. How do we as leaders in healthcare adapt to the modern learner? We're going to be speaking about implications of new horizons, as well as the influence of artificial intelligence. And my hope in this presentation is that it will not only provide you context as leaders, but most importantly, help you generate salient questions as we look into the future of healthcare. I want to start out by introducing myself. I am a proud graduate of Northeast Ohio Medical University, part of the BSMD program. I did majority of my pediatrics training in Ohio with a brief 3-year hiatus to Georgia, much warmer weather, where I completed my pediatric critical care medicine fellowship. This past year was very exciting. My wife and I finished 5 years of long distance, and my wife, Kushali Shah, is also a proud graduate of NEOMED. This past year, I completed my master's in medical education, and I want to provide any trainee or junior faculty who may be listening to this presentation to utilize leadership as well as passion to drive you forward as you fill a gap in an institution. My biggest takeaway as we conclude this introduction is to be indispensable, having a lens of being adaptable and embracing change. I would define myself as an early adopter, and this is something that I'm going to be sharing with you as we go through our lecture today. So the goals of my presentation today are to illustrate the modern learner, as well as highlight the bedside teaching challenge that we have as educators. We're going to explore the current influence of AI in clinical decision-making, and finally, convey the role of the institution in influencing change. Now, a picture at times paints 1,000 words. And if you look at this image, what do you observe about the modern day learner? Well, notice how the traditional textbook is going to sit in the foreground, while her personal phone and the devices next to her are likely buzzing with notification. Now, she's looking away from the textbook, wearing headphones, and perhaps it's to help her focus, or maybe exploring an alternative learning method like a podcast in her ears. Now, in the background, we see a trainee engaging in bedside care where application is paramount. And interestingly, there is a young child on the left here engaging with the computer, possibly interacting with the AI digital trainer. This may be alluding to the up-and-coming generation that has already been incorporating the use of artificial intelligence into their daily practice. So the challenge that we have as leaders is perfectly defined by just standing at the corner of East 93rd and Euclid Avenue in Cleveland, Ohio. This is a picture of our health education campus and medical school in the summer, which is much warmer than where we are right now. It is uniquely juxtaposed across the hospital. And what keeps me up at night, especially in my role at the medical school, is how do we balance traditional education in the classroom and translate it to the clinical setting where high-value, team-based, patient-centered care is paramount. In other words, while medical knowledge in the classroom is neatly organized according to the curriculum, in the clinical setting, it must adapt to the dynamic, complex, and for us in the pediatric ICU, often predictable nature of real-world patient care. So now what we have to unpack is defining the modern learner and a clinical critical reasoning model for high-value bedside medicine. Now, what does the literature state about our modern day learners? In a multi-center cohort of medical students, 81% of participants prefer digital resources. Additionally, in a scoping review of medical students, over half of the cohort utilized content from YouTube to help pre-read for foundational science classes. In the graduate medical education arena, in a single center cohort, over a third of the residents followed a social media influencer for medical content. And what I find most interesting is that many undergraduate students on campuses are using AI in their assignments and coursework. Remember, these are the future medical students and graduate medical education learners. So I want to summarize this portion of the talk by providing an anatomy lesson on the modern learner in medical education. The modern learner is tech savvy and digitally oriented, preferring tools like apps or podcasts for flexible on-the-go learning. They favor short modular content that maximizes retention and accessibility, with engagement heightened through visual aids and gamified platforms. Additionally, modern learners value collaboration. They are social learners, and this is quite the shift as we are in this post-pandemic era. Increasingly, learners are leveraging AI for personalized learning, reference, and diagnostic reasoning. In fact, a recent JAMA Open Network study noted 42% of medical residents and fellows use tools like ChatGPT. And in my opinion, this is probably underrepresented and is increasingly getting popular. The point here is for us as leaders to drive the needle forward. We must adapt and understand the modern learner. So we've defined the modern learner. How do we merge this phenotype with traditional pedagogy? To bridge this gap, I'm going to cite one of my favorite books on learning, Make It Stick. It was written by a group of cognitive psychologists at Washington University. And one of the more popular quotes from this book is the following: learning is deeper and more durable when it's effortful. Learning that's easy is like writing in sand, here today and gone tomorrow. So as leaders, our current role is to create a safe learning environment for our modern learners, where generation of questions, elaboration of concepts, and reflection of sentinel events is celebrated, but also an environment which actually holds them to a standard and has increased effort to establish competency. Remember, the goal here is to make the learning environment safe and durable. We want long-lasting change. Now, if we look at my role as a clinician, at the bedside, I'm usually not as focused at times about the content, but rather focusing more on pushing the trainee to generate more questions to learn deeper from our patients. These questions help clarify concepts, probe for reasoning for evidence, and also explore the implications and consequences of decisions. Now, when I am in my role as the Associate Program Director for our Pediatric Critical Care Medicine Fellowship, I always tell the 3-year fellows that the first year is understanding why things are happening. The second year is the practical management. How do they effectively do it? And the third is developing the best question. Why can't I do it this way? The summary of this slide is to emphasize that medical education isn't about the content knowledge that is imparted on our learners, but rather the questions we force our learners to generate and answer. Now, in the purest sense, because we've talked about the modern learner preferring an engaging learning environment, I'm a firm believer that a Socratic approach to teaching and forcing students to ask and answer questions can practically help augment the learning environment. Many of us are familiar with the term pimping, which was published in a JAMA article in the late 80s. However, in the contemporary context, creating a psychologically safe learning environment is paramount to connecting the learner's emotional state and the physiologic process of learning. Making sure that your learner group feels safe to continue to take risks and be vulnerable in front of each other is key. At this point, I want to highlight one of my favorite quotes on active, engaging learning. When we think about learning, we typically focus on getting information into students' heads. What if instead we focus on getting information out of a learner's mind? To build on this critical thinking module, how can we engage the modern learner to contrast the various clinical presentations that we see at the bedside? I think it's important for us to understand the difference between deductive and inductive reasoning, as that can really help facilitate a learner ascertaining the most from a patient encounter. So to define these, deductive reasoning challenges the learner to take one fact and generate multiple hypotheses. For example, the learner would take a single observation like hypotension or low blood pressure and generate multiple diagnoses, after which the learner can back map facts retrospectively to come to a diagnosis. Now, if we contrast that with inductive reasoning is where multiple facts generate a single hypothesis. In our case, putting facts of hypotension, decreased hematocrit, and elevated BUN and creatinine would lead to a broader list of explanations or a hypothesis that would include bleeding. No study has really found either model to be superior. However, inductive reasoning forces the learner to come to a working diagnosis based on many data points and on different mechanisms of disease. We're going to continue to build on this learner engagement model. So far, we've talked about the importance of generating the most effective questions. We've also talked about how it is important to have a reasoning model that is either inductive or deductive. But I think it's also important for us to be mindful of cognitive biases, which can convolute the learning or decision-making process. For example, anchoring bias is when the team may hook onto salient aspects of a case early in the diagnostic workup, creating diagnostic momentum without revisiting key data. So the layer that we will add on this model is to be aware of biases, both personally as well as when we teach clinical reasoning to learners. Now, as you can see, we have this layered approach of various educational components. And on a day-to-day level, what we can do to teach more effectively at the bedside is get a culture of deliberate practice. This is a term heavily studied by cognitive psychologists, specifically Anders Ericsson, who coined the term the 10,000-hour rule. And he looked at studies of expert performance in chess grandmasters, classical pianists, and NBA all-stars. And this idea of deliberate practice is one of the cognitive frameworks behind simulation, and that can help a learner go from where they are currently to where they want to go, i.e., their goals. So I think the aspect of deliberate practice, which I would like to impart on you, goes beyond the notion that practice makes perfect, and even beyond the walls of the simulation center going through scenarios. I would like for us to think about creating an educational environment where we can not only analyze our learners' performance and provide feedback, but moreover, spark within the learner that he or she needs to improve on some element of their performance, allowing them to introspect and have goal-directed practice with hopes of assessing their areas for improvement. The ultimate goal in this dialogue is to actually celebrate mini wins and increase the level of difficulty in the learner, pushing them outside of their comfort zone. Because as you can see here, clinical growth is going to come whenever we push the learner beyond their comfort zone. And this is what philosophers in education, Vygotsky, for example, termed the zone of proximal development. We need to see where our learners are in this paradigm and push them to higher and higher heights. Now, I do want to conclude by commenting on an emerging topic, the influence of artificial intelligence in the clinical environment. We've just developed a model where we are defining the medical education learner and creating a critical thinking framework for them to iterate on. But now the question becomes, how do we adapt this new AI technology, which learners are increasingly adopting? How do we incorporate it into our bedside care? Now, before we go on this AI frenzy, in medical education, we don't just implement tools because they, quote, sound impressive. We integrate them when they meet the standards we expect from clinicians, for example, competence, reliability, and ethical responsibility. And that brings us to this next concept, entrustment requirements for AI in medical education. Just like we assess whether a trainee is ready to independently perform a task through an entrustable professional activity or an EPA, we need to apply the same principles to entrust AI. So for AI to be entrusted in medical education and patient care, it must demonstrate three qualities. Ability, can it perform accurately, reliably, and safely? Integrity, is it transparent and explainable in how it reaches to different conclusions? And benevolence, are its goals aligned with the best interests of learners and patients? So here is another study that is amongst the body of emerging evidence that shows AI-assisted clinicians are able to have superior diagnostic reasoning on clinical challenges compared to unaided clinicians. As you can see in the blue line, this represents the clinician unassisted and the percent accuracy of getting the correct differential diagnosis on difficult cases. Now, if you shift your attention to the yellow and red lines, what you see here is an AI-assisted clinician actually has increased in diagnostic accuracy. So what's the takeaway here? Rather than replacing human expertise, AI has the potential to elevate clinical decision-making, improving accuracy where it matters most. What I think is important as we look at AI's influence on clinical reasoning is that large language models provide support without extra time or cognitive effort. Large language models boost diagnostic accuracy and comprehensiveness. And what I want to emphasize here is large language models work best when combined with human intuition. The buzzword that I want to convey here, we have to have the human in the loop. AI enhances, but should not override clinician decision-making. Now, as a unique technology, it is important to understand the nuances. In order for us as leaders to adopt this technology and to be effective educators, we must critically stress to our learners the importance of having the human in the loop. Right now, this is an emerging technology that is changing at a rapid pace, and having the human in the loop helps us delineate what is truth or what is hallucination. Specifically, it is important for us to highlight to our learners the importance of owning and modifying the output generated from a large language model like ChatGPT, And also citing or being transparent when you use a large language model, knowing the potential pitfalls of hallucinations, as well as even some of the institution's viewpoints and limitations of incorporating this technology. Now, so far, I may have played the side of the coin where I am all for AI. However, I want to make sure that we have a balanced perspective and viewpoint. We've talked about why this technology is so powerful, but if we're going to adopt it responsibly, we also have to be honest about the flip side, because every tool that reduces friction can also reduce effort. And in learning, effort is not a bug. Effort is the main feature. Remember, durable learning is effortful. So a growing concern is what some people are calling cognitive debt. And I'll say it can be also termed cognitive obesity. In other words, when we outsource too much thinking to a large language model, we can end up paying interest later in weaker understanding. Now, this was a very popular study done at MIT. And what was noted is that those participants who just over-relied on a large language model to, let's say, write an essay, they had lower brain engagement. They had a portion of their memory essentially being impaired because they don't remember necessarily the outputs from the LLM. And finally, the creative process was not as robust when AI was generating the essays. The point here is for us to recognize that over-reliance on AI can erode critical thinking, creative thinking, and deep learning. And so having that balance is essential. Now, many of the strengths and limitations we have discussed are more focused on the personal lens. However, I think it's important for us to evaluate this technology at the institutional level. And this is where the institution has to be involved. And many of you listening here are leaders in your domain and are able to influence the institution. And here's how I would practically break it down. It's about understanding the educational culture and making sure that it is a psychologically safe culture that is going to embrace discussion, have accountability metrics that value teaching, tolerate ambiguity, and have full transparency with the constituents. Educational culture involves an institution being nimble, tolerating ambiguity, and being transparent about it, as well as engaging in this culture of discussion with tangible outputs. I always like to say ideas without execution are delusions. So in order for an institution to embrace a adapting and evolving technology like AI, resources must be redistributed. And this is a challenge that many of us are not unfamiliar to in our current healthcare climate. So as I close this part of the talk, I view large language models integrating into our education and clinical strata, similar to a scalpel, which I use in the pediatric ICU for a procedure. It offers immense potential or benefit and can sharpen clinical reasoning for our learners. However, just as a scalpel needs a sharps container for safe disposal, AI's efficacy in medical education requires careful handling to navigate its limitations, and we must support our learners to critically appraise the large language model outputs. We're going to go back to our star patient, Georgina PT or GPT. She's a 25-year-old PGY1 pediatrics resident and a graduate of NEOMED, eager to prepare for her first inpatient rotation. Her evaluations praise her for being professional, but highlight that she, quote, just needs to read more. She attends didactic sessions via Zoom, but finds herself distracted, occasionally checking TikTok, where her favorite MedEd influencer, PedsResDocMD, recently shared a mnemonic on pediatric vaccines. She feels overwhelmed on how to balance knowledge acquisition as her attendings keep just sending her PubMed articles, and she finds that she gets better learning from researching her patients with open evidence. Of note, she only has read a few pages of her textbook at her local coffee shop on weekends off, and she finds it important to attend the monthly sushi nights with her co-residents to maintain her sanity. Of note, she used ChatGPT to write an email to her program director for an upcoming schedule change. This is the anatomy of our modern learner. And many of these sentiments you probably can share and relate to as you reflect on your personal clinical practice and educational space. And I want to end on this quote today. This was recently cited in the Harvard Business Review. AI will never be able to replace humans. However, humans with AI and understanding the confines of it have a potential to replace those without. Now, I'm not trying to say that we need to go into this AI frenzy, but what's most important is to embrace the skill of adaptability. And that is what defines a true leader. Thank you for your attention and look forward to the question and answer session.
Dr. Damania, that was outstanding. Thank you. We are so proud of you as a NEOMED graduate who is making a difference, not only for the lives of your patients and the learners, but really for the upcoming generation and all that you do. Thank you for joining us today for VITALS, the Health Leadership Forum, and we'll get right into the Q&A.
I'm looking forward to it.
So can you talk about the leadership lessons that you've learned on your path?
I will say that some of these lessons I have learned the hard way, but one lesson sticks out, and that is being dependable. I always like to say that it's not about being the smartest in the room, but the one who can effectively communicate and deliver after setting an intention. This is something that I work on personally and also train the fellows to embrace as well, being dependable.
Let's talk a little bit more about AI. I think that you did a great job explaining how it can be an asset, but at the same time, we are all still figuring it out, and particularly in the medical field, there's so much potential, but there's also concern about harm. So can you talk more about ways that medical education might be able to adapt to AI for the betterment of all of us?
I think right now, AI is a tool that helps augment our performance, but should not substitute our performance. The key here is for us to establish truth with AI by taking ownership of the outputs, checking the citations, understanding that AI is basically a probability model, and our clinical and critical intuition is what's going to be the most pure. And yes, AI is a technology that is rapidly evolving, but the more that we understand the use of it and when to use it, how to use it, I think that is going to help us as we go into the new horizons with this technology.
And how does that all tie into the phrase you used, high value bedside medicine?
I want to talk a little bit about a two-channel learning model. And this actually won a Nobel Prize by Daniel Kahneman, who was a professor in economics. And he said that our mind operates in two channels, systems 1 and systems 2. And systems 2 reasoning is when we are a little bit more hypothetical deductive or algorithmic. It's kind of like when a clinician says, what else could this diagnosis be? And I think this is where AI can really help. When you have a question which you want to build your own personal confidence with, a tool like ChatGPT or Open Evidence can allow for you to ask the right questions and substantiate your confidence.
This perspective is important coming from you based on your role as it relates to undergraduate medical education and graduate medical education. Can you talk about how those differ and how you balance it all out in addition to your clinical role?
I've been very grateful to be on a full spectrum of learning, both medical students as well as clinical trainees. And one of the most humbling parts of this is for me to understand where a undergraduate learner is going, but also where a graduate learner came from. And as I continue to take on these roles, I center myself on not just work-life balance, but work-life integration. Because in healthcare, that is the goal, is to not think of it as binary, but at times think of it as integrated approaches to prevent burnout.
The message that you gave through your presentation really speaks to medical professionals at all levels. Those who are about to enter the field, those in their residency, those who are teaching. But when you look at some of the takeaways about balancing the leadership styles and when people should start to think about what can I do in my position right now to get better so that I can help move education forward so that healthcare overall improves for the people who are being served?
That's a very challenging question, and I don't think I have the best response to it. But what I will say is to seek to understand before conveying what you want to say. And this involves you having more conversations, understanding what is the true gap that institutions are facing, and on a personal level, developing your skill set so you can fill that gap.
So let's talk more about that skill set. And when it comes to clinical judgment and at the same time balancing that with humanistic skills, what guidance can you offer?
It is important for us to not just be robotic and keep churning out the content, both from our minds as well as a large language model. The humanistic element comes from one key word, and that is relationship. In this very fast-paced healthcare system right now, the ability for you to develop relationships quickly in a genuine nature, and sometimes not doing your best, but doing what it takes, really can help you be the all-around, well-rounded clinician. And this is something that I like to coach with the trainees, is to make sure to be humanistic, have that sensitivity that these are patients in their most vulnerable times.
What can medical students do right now at their level to start focusing on that critical thinking?
That's such a great point. I think diving in head first into the clinical arena is something that a young medical student can do. And in particular, finding a mentor. And I know there's a lot of talk on social media, for example, on mentorship, but here's one key point that I want to bring up regarding mentorship. Sometimes the best mentors are not the ones with the most experience and the highest position. In fact, some of the best mentors are 1 degree of separation away from you. They may be just that recent graduate from NEOMED that can serve as your mentor. And maybe that person doesn't necessarily have all the publications or all the experience. But when you have a proximal mentor 1 degree of separation away, that person can learn with you. And they understand one key thing, the beginner's mindset. This is something that I think all medical students should really focus on as they go year to year and graduate.
Well, that's great advice. And I'm going to put you on the spot. You talk about that 1 degree of separation. Do you have any examples you want to share your own experience, whether it was here at NEOMED or during your experience getting your master's or during your fellowship, where someone made that type of difference for you?
Absolutely. I think that there are so many instances. And I remember one in particular where during my master's coursework, I was able to sit down with someone who had been very published academically, and they were trying to understand how to get into more of an entrepreneurial space. And I think it was such a creative discussion because now we have a reverse mentorship model in which they are really trying to hone in on my academic skills, and I am giving them some insights from my entrepreneurial journey. And this is really the mecca of what we're talking about today, is building effective relationships.
Well, let's talk about your entrepreneurial journey and Hi Guru. Tell us what that is and what the business focus is.
That's a great question. And I will tell you, in sum, Hi Guru is my baby. And why I say that is because it started at NEOMED in the back of the library. And now it has translated to be one of the fastest growing platforms for USMLE or board review preparation for preclinical students. Hi Guru is an innovative approach that allows for students to learn medicine through vignettes, cases, how patients present. And this has been something I've been passionate about because the traditional learning lens was to take, for example, anaphylaxis and put it in 3 bullet points on a PowerPoint slide: wheezing, diarrhea, and hives. But now I have shifted that paradigm. And in my videos, I teach anaphylaxis like a 4-year-old child just went to a birthday party and ate peanut butter, and now they have hives, diarrhea, and wheezing. And so this is exactly how I feel students can learn, is once they have a little bit of context, they jump into Hi Guru, which is a platform that pushes their clinical reasoning as well as gives them exam performance, because on exam day, they're going to be exposed to many different clinical vignettes.
So everything that you just described is absolutely essential to step preparation.
Absolutely. I think not only for step preparation, but going beyond the boards and understanding that if you have solid medical knowledge for practice and you combine that with empathy, you're going to be the consummate clinician.
So something we talk about here on Vitals a lot, it does have to do with professional development, as if getting your MD isn't enough. There's so much more that is required in the world that we live in today. So again, if you can talk about your decision-making process that propelled you forward to want to pursue your master's degree, and if you can expand on that a little bit.
Sure. I think that the master's in medical education was well positioned. And why I say that is because before I embarked on the master's, I ended up creating an educational company, starting a podcast, a social media brand, collaborating with medical schools to teach USMLE preparation. And I think having that context and then back mapping it to the various pedagogies or theories that I learned in the master's was very effective. And I think it's important for young trainees to recognize that just running into a master's of public health, master's of business, master's of education is not necessarily as effective as you iterating in that interest a bit and then getting formalized education on it.
Thank you. So what is a day in the life of Dr. Damania like?
Well, I will be very vulnerable and say it starts very early. I wake up about 3:30, 3:45 a.m. and I have quite the morning routine, but I also couple that with some spirituality and opportunity to really get deep work done. I think that before the pings, rings, dings, it's important for you to have that moment to yourself and understand what are the different priorities as you go into the day and how can you make sure you deliver on some of the promises you've made in various different domains. So I am so grateful to have a fulfilling clinical job and couple that with both entrepreneurial and teaching endeavors. And the best part of my position is to work with trainees and see them grow.
Can you talk also a little bit about your clinical experience and what is most rewarding about that as well? Why you chose the specialty that you chose?
Thanks for asking this. I am very humbled to say that I had the opportunity when I was at NEOMED to fortunately and unfortunately be on the patient side of medicine. My sister ended up having a very severe brain hemorrhage, and that landed her in the pediatric ICU. And I found that journey to be very humbling. It was sad in the moment. And now when I look back at it and full circle, now I'm a pediatric critical care physician. I find that having that lens of what patients are going through day to day, I still remember sleeping next to my sister who was on the ventilator fighting for life and death. I never let go of that vision, because whenever I see a family in the pediatric ICU, I treat them with the most respect and understanding of what their emotions are, as it can be very heightened whenever their child is sick.
Thank you for sharing that very personal moment. And I'm sure your patients and their families are very grateful for the compassion that you show them, that is informed by your own experience. Thank you, Dr. Damania. Is there anything else that you want to share that might be encouraging or uplifting to our audience? Because this is hard work that they've signed up for and that they pursue. And seeing someone like you do it in itself just sets a wonderful example.
Well, thank you so much and appreciate your kind remarks. I want to end with this and citing one of my favorite authors, Angela Duckworth. The definition of grit is going from challenge to challenge without losing enthusiasm. And in this game of life, it's so important for you to maintain enthusiasm of the process rather than the outcome. And that can extrapolate in any domain which you contextualize it in.
Thank you, Dr. Damania. You have given us all a really encouraging, uplifting, insightful presentation that is empowering for healthcare professionals everywhere. And now we're going to turn it back over to Dr. Lanchel.
Thank you for joining us for Vitals. We look forward to seeing you for next month's presentation. Visit neomed.edu for more information.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.